Well, with healthcare systems in the US, especially hospitals, or when they turned over much of their operations to treating patients with COVID-19 this past March, they did suspend and postpone a lot of non emergency surgical and procedural care. Now, telemedicine filled an enormous gap in healthcare for anything worrisome or easy to address remotely, and emergency departments remain ready to deal with anything life threatening, including strokes and heart attacks. We now know, although we're still trying to figure out the reasons behind this, that fewer people than usual wound up in hospital EDs the past few months if it wasn't COVID related, which begs the question as services resume for non urgent matters, will patients come? We don't know all the reasons why people stopped coming to the ED, especially for things like strokes and heart attacks. So we're now trying to figure out, well, will people come back if it's non urgent? That's certainly what many health systems are counting on as they develop detailed plans for getting in person, non COVID related healthcare up and running again. So we've got someone with us to explain what's going back online and how they're going about it with COVID-19 still a major threat and factor. And that's Dr. Anthony Petrick. He's a bariatric surgeon and chief quality officer for inpatient services at the Geisinger Health System in Pennsylvania. We were going to also have Michelle James, an executive director of the Providence Nursing Institute at Providence Health and Services. She's unfortunately not going to be able to join us today due to some last minute unforeseen circumstances, but she did very much help with today's program. And of course, we welcome back IHI's Don Berwick and Derek Feely, our regular expert panelists on these virtual learning hours. So hello to all the panelists and hello to everyone joining us. So you're going to hear from the panel for about 30 minutes and then we'll turn to Q&A and discussion. You can chat in questions and your thinking throughout the hour. We'll address those questions though in the second half of the show. And remember, chat to all participants. So we're going to start, as we often do, with some framing and perspective from Don Berwick. And Don, as we're going to hear from Tony in just a few minutes, a lot of what goes into resuming non-urgent surgeries, diagnostic procedures is at one level very technical. It's blocking and tackling some pretty familiar services in a hospital today. Yet at another level, given what's gone on with this pandemic, it's something else altogether. How might you characterize some of the challenges to get our discussion going? Thanks, Don.
Thanks, Madge, and it's a pleasure to be with you all today. Thanks for sticking with these virtual learning hours. They're really a pleasure for Derek and me and Madge and our entire team. Um, this, it's interesting with all the networks that IHI has that I have the privilege of connecting to. They're kind of questions come and go, like surf is up on certain questions. This is definitely the question of the hour. I see more activity around the question about reopening in the past week or two than I've seen about any other topic in the COVID world. Last night we actually had a meeting of the IHI Leadership Alliance, and one of the members said that if she said we thought closing down healthcare was difficult, but it's nothing like the difficulty of reopening. So as you said, Madge, there are technical challenges here that are phenomenally hard, and I think sharing information from Dr. Petrick and among ourselves is going to be really helpful as we find our way to an answer. There are some themes that are also emerging. One of them is safety. There's been a lot of concern and a very eloquent email. I don't know if we ever shared it from Jim Reinertson, one of our senior faculty, around what we know about teams that shut down and then reopen. And there's actually very good science that shows the re-upping of teams that have not had the experience of working together for some time is actually a pretty dangerous period. And there may be ways to mitigate that. And maybe Dr. Petrick and others will speak about that, how to kind of take a breath, realize we're not at the edge we were when we shut down a service, and we have to go through some serious safety practices in order to prepare safely to reopen the services. Another is a sort of equity and logic, like what do we open and what not. I was on no less than four webinar meetings yesterday, four, dealing with the issue of reopening, and all we're dealing with problems of sequencing. What's the first thing to do? Who needs us the most? Or what's best to reopen? And I'm sure we'll be talking about that today. As I said, surf is up on this. Everyone's talking about it. You're I think you were kind to ask me to opine, but I think, as Dr. Patrick, I'm sure will say, this we're learning together. No one's had to do this before, and so this is a time for real agility, building the plane while we're flying it, and being step by step learners as we get into this difficult task. Anyway, I'm really anxious to hear from our guests and from our participants, and thanks, Madge, for the chance to join us again today.
Here. Thank you very much, Don. All right. Well, we're going to turn to Tony. And again, welcome to IHI's Virtual Learning Hour. So, Tony, Dr. Petrick, every health system, including Geisinger, has a COVID-19 calculation it has to make when restarting services. So, take us into the world at Geisinger and what the system has factored into its decision making. Thank you very much. Whoops, we got to get your mic off on. There we go. You are, yeah, come a little closer if you can.
Got it. Yep, I will.
Thank you. All right, that's good. Thank you.
Okay. So what we factored in is, I think, very familiar to a lot of folks. A lot of it has to do with the prevalence of COVID-19 in our regions. So one of the things we first have to look at is what are the regulatory requirements to restarting. Most people are aware that we had a lot of relaxation of some CMS guidelines and some JCO guidelines, and each of our states is very different. I like to, we kept this somewhat succinct in terms of my presentation, but I like to show a map of Pennsylvania, and really it just shows it's sort of a model for the country. That our county map looks very, very different in our southeast, our northeast, our west, and our central regions. There's no one size that fits all for the country, and Pennsylvania is exactly the same way. Our health system really spans from the northeast, which a region which abuts northern New Jersey and New York, where they had the highest prevalence in the country, if not the world, to some very rural areas that had one or two cases. I don't think we ever wound up with a county with no cases, but we've got several counties in the state that have no cases. So we have hospitals in all those regions, and trying to reopen elective surgery and clinics as well in an environment like that was very complex. One of the things that, and the state didn't give us a lot of guidance, but one of the bits of guidance they gave us are really two things. They want us to make sure that there was a sustained reduction in the rate of new COVID cases for at least 14 days. And what you see in the line graphs next to you, next to the slide here, is the higher graph shows our different regions that we serve, and just drives home the point that we're serving very different regions. We had prevalence of as high as 300 per 100,000 in our northeast regions, which are Scranton and Wilkes-Barre, and yet we look at our central region, which is where our largest hospitals are. They're about a fifth in terms of the prevalence. Those lines, that was halfway through May. Right now, those have continued to trend down. So we wanted 14 days. We're probably at 4 to 5 weeks now of a downward trend. For just comparison, the New York prevalence per 100,000, New York metropolitan area is superimposed in red in the lower graph. So you can see that their prevalence is close to 10 times most of our service regions. So just to drive home, different problem in different areas of the country. The multi-society statement was put out on April 17th from the American College of Surgeons, the American Society of Anesthesiologists, AORN, and the American Hospital Association. That document really kind of serves as our roadmap, and in Pennsylvania, we were referred to it. The second thing, in addition to a trend, is the prioritization system for scoring. So we can go to the next slide on that, Madge. The multi-society statement asks for this prioritization system. The American College of Surgeons very early on published a prioritization system that wasn't real functional at the end of the day. It was theoretically very nice. It came from the University of St. Louis. It suggested a tiering system with multiple sublevels of tiers based on the clinical condition of the patient. And what we learned were there's a lot more factors that go into that. We really simplified it. And we actually turned it upside down. The ACS system suggested that tier 3 were the most urgent cases. That was counterintuitive to most of our providers. We worked with it for about 4 weeks. We got so much pushbacks from providers saying, why is tier 3 the most urgent? Tier 1 should be the most urgent. And so finally, we turned it upside down. But we tried to keep it simple. Tier 1 were the most urgent. We define that as posing an emergency or urgent threat to life and limb or serious threat of clinical deterioration. Tier 2 is our really the bulk of what we're trying to bring back right now. We're referring to as non-urgent cases. They're planned for clinical conditions that pose a non-urgent threat of clinical deterioration. And then tier 3 are our most highly elective, which you might think of as cosmetic or those for asymptomatic conditions, those that pose little or no threat of clinical deterioration. So clinically, we tried to keep that scoring system as simple as possible. In this interim, the University of Chicago has suggested a system called MENDS. It's a much more complex system for clinical tiering of cases. It actually is very useful. It takes into multiple considerations. We have used that system just within our departments, our divisions, or our individual practice. We've allowed providers to say within your group, you can get a lot more granular in terms of how you tier your cases. But when we get to our ORs at the hospital level and we're talking about multiple specialties, essentially, I hate to use the word, but competing, because I think most of us understand there's a real energy about getting back, both from the providers, the staff, the patients. We're trying to keep it simple. So next slide. So the next thing we did was look at the cases relative to our hospital capacity, and that really goes back to these maps that show we had hospitals in our Northeast who had ICUs on bypass for 2 weeks, every day for 2 weeks. Their ICUs were filled to capacity, and their patients were being transferred down to our main hospital in Danville, their ICU overflows, their ECMO patients. As we brought this back, we realized that we have 9 inpatient and 3 ambulatory centers in our system, that there were some that had lots of capacity and we could bring back almost any case, and they had very little cases. There were others that had very little capacity. So our approach was to look at the type of anesthesia. Was it local, regional, or general? Our earliest phase focused really on local and regional anesthesia. What was their pre-authorization status? In other words, were they going to be an ambulatory patient and go home? Were they pre-authorized for an overnight stay, or were they an inpatient? And if they were an inpatient, we looked at their disposition. Were they going to be a med-surg patient or an ICU? So again, our simplified prioritization system was based on 3 tiers of clinical acuity, anesthesia, pre-authorization status, and ultimate disposition if they were an inpatient. So next slide. We wanted to have some guiding principles that we conveyed, and I'll refer to the way we launched this and kicked this off throughout the whole COVID state of emergency. We had routine town halls. They started off weekly, but we had health system town halls run by our senior leadership, including our CEO, as a tool to really try and communicate with our entire staff. We actually also did social media events for our communities, our businesses, and our patients in the community. So, but we wanted to start off with some guiding principles, and we think it's important that there be transparency about the process, that people understood really as best we could how we came to this the decisions about when to start and how to restart. We were committed to continuous monitoring of COVID-19 in our communities. This was a must. We had to do this so we understood our bed availability, and we could adjust our different phases of resumption of surgical services, which I'll allude to next. We had to have continuous monitoring of our PPE and our blood supply, and we've developed real-time dashboards for all of those. And we've developed probably more dashboards in the last 2 months than we develop in a year usually, to try and make sure we knew where we stood in as close to real time as we could. I already referred to the standardized tiering. We're going to talk about the phased resumption, and we really tried to pay a lot of attention to supporting our employees' health and wellness. Many of our employees were redeployed. There's tremendous stress in the community about the economy. For one thing, we're not in an area that has one of the more robust economies. And there was real concern. Our health system really is the biggest driver in the Susquehanna Valley, economic driver. We did not have to furlough any employees whatsoever, but employees did have to take mandatory redeployment. And one of the most complex parts of this process is how you undeploy, in quotation marks, staff who has been redeployed. What's the right timing? What we do realize is that we have COVID-related positions that are going to be permanent for the foreseeable future. Those have all been manned by staff that were redeployed. Most of our health systems are losing a significant amount of money. Hiring people is actually not real high on people's priority list right now. Yet it may be something that we have to look at doing. So these are really complex things. They all interact with each other. It's a very complex puzzle, and you can't do one thing in a vacuum. And that gets back to the communication piece, because many of our surgical providers or our staff in the OR or our clinic staff see things through their lens, which is a very limited lens. And to get them to understand and have an interest in these more complex problems is difficult. So next slide. So our phased implementation, we really called phase 1 and 1B. We started May 11th, and we really focused on our ambulatory center, just really our biggest ambulatory center, which is in our main hospital. Patients had to be dispositioned home. They had to be COVID negative, and I'm going to talk a little bit more about testing. We had to look at the capacity of the center itself, so we had to get our redeployed staff back. We thought we'd just do regional anesthesia. It made sense to do all anesthesia just based on the cases that could go in there. They were ambulatory. A lot of those were ortho cases that had really stacked up. I'll tell you that at our peak, our number was just over 6,000 cases that were postponed in our health system. We're just starting, and we have another real-time dashboard that we use to show how we've impacted those postponed patients. It's a lot of people to reschedule. Prioritization, we were only going to use we always did tier 1 cases, and that's a point we want to make, and I think it's important to make across our systems as people express anxiety about coming back to less urgent procedures, is that our staff and our surgeons have been operating throughout this whole state of emergency on the most urgent patients. So we haven't shut down completely. But we were going to address the tier 2, which are patients who have either progressed during their postponement. We're going to leave the most elective patients till later. And we had to create some system standards for documentation. We had to talk to people about the risks that they were facing, about the risks they may pose to our staff as we put new processes in place that really address the COVID-specific issues. So we were able to do that the first week, during the week of May 11th. Phase 1B, which really overlapped, it started out probably around Wednesday of that week, opened up some of our other ambulatory care sites in our system with very much the same criteria. So if we go to the next slide, the next phase we called phase 2. And in phase 2, it differentiated by we allowed overnight stay patients. So it wasn't all ambulatory patients. It was overnight stay patients. We looked at their post-op disposition. They couldn't have an expected ICU disposition. It had to be a med-surg bed. We were able to start this the following week, so 7 days later. And we took all tier 2 cases. Initially, we tried to avoid those with high aerosolization risks. Some of our ENT cases and all we wanted to avoid in phase 1. We were able to roll that out, and quickly in our central region, we found that our med-surg capacity was nearly 100%. And like many facilities, we had 20% of our beds, roughly 500, were dedicated to COVID units. We were seeing a decline in our inpatient COVID patients, but trying to find the right balance as to when to take those units down and provide beds for non-COVID patients was a struggle. It was a daily conversation with our CMOs, our chief nurses, and we had to work through that. We told all our providers that when you schedule your cases, these non-urgent cases, there is a chance that somewhere close to the surgical scheduling date, we may ask you not to do those cases, and they had to understand that. Fortunately, we didn't get into that situation, but we had to be able to do that. phase 3, which really started the following week, this week, has been all patients, including inpatient and ICU. We actually have more capacity in our ICUs right now than we do in our med-surg beds. We've taken down a 20-bed COVID unit, so we have 2 COVID units that we've actually taken down in our main hospital. We've seen a dramatic decrease in our Northeast, which were our fullest hospitals. So our Northeast regions were able to rapidly move up to phase 3 and actually are posting some elective phase 4 cases right now. And that's really is the crux of our approach. We felt that trying to get really too detailed about trying to coordinate at a very high level between clinical specialties, clinical needs would result in an awful lot of conflict. And you know, I've had, in my experience doing a number of these with our bariatric population, I've been interested to hear the approaches where they've tried to do that. And again, I think it's been more challenging, and I think it does start to pit providers against each other. So we've been very happy with this approach, but as Don suggested, you know, there's no playbook for this. It's something that we've had to work with people around the country to just try and share ideas and really coordinate communication across our system. So I think, go ahead.
Yeah, let me jump in there. Thank you, Tony. You've really laid out quite a bit of information already in these first minutes of the program. And thank you all who are making some comments in the chat. I think we're going to end up, just because there is so much to learn, we'll probably compress a little bit some of the information about testing, but know it's of course that it's its own very carefully tuned program. I think what I want to do is just pause for a moment. I'm going to invite Derek, and then maybe if Don also wants to say something, even at this part of the program. I noticed, for example, in a lot of the chat already, we can see that people are, we have a wide audience. Not everybody is involved directly in surgery, of course, and there's a lot of concern about staff well-being, adjustments, bringing teams back together, among other things. Derek, some thoughts from you?
Sure. Thanks, Madge, and thanks, Dr. Petrick, for your really helpful insights. As you said in the chat, Madge, those folks who are really interested in the emotional well-being of the caregiver teams will only have to wait 7 days until we really dive into that in the next iteration of this program. A few things really resonated with me in what Dr. Petrick was saying, and also in your introduction, Madge, and Don's words. The first is just to echo, I think, the sentiments expressed by everyone that restarting is likely to be more difficult than stopping. We've got testing to contemplate. We've got the availability of key staff. We've got that issue that Dr. Petrick referred to about the redeployment of the already redeployed staff, which is likely to be a challenge. There's no switch that can just be turned on here. This needs, as Dr. Petrick said, needs a roadmap. It needs a system, it needs a plan. And I think for me, there are probably 3 things that seemed essential in that plan from what folks have said so far. The first is that we've got some work to do to rebuild patient and family confidence in the system, in the safety of our system and in its quality. And we're not going to be able to achieve that unless we involve and engage patients. And so I think this is an excellent time for us to be, as we're getting ready for restarting, to be engaging with our patient advisory groups, to be elevating patient voices, to deeply understand what are people's reservations about seeking care at this time. I don't think we should make any assumptions about that. Second, quality and safety need to be integral to this. We can't We can't restart and then worry about safety. That needs to be done in a contemporaneous kind of way. We need to be thinking about the quality and safety as we restart, or maybe even in advance. And then the third is the importance, and this has been a feature in the chat, Madge, the importance of taking this opportunity to redesign. So as we restart, let's not just automatically go back to what was before, but let's think about what does this mean for how can we use virtual care, telehealth and telemedicine, as we've talked about previously in this series. How can we use this pause to really address some issues around overuse? Trissa Torres identified in the chat as a real opportunity for us, and I think that's absolutely right. So those, this is going to be hard, and as we do it, those three things, Mad, seemed important to me: the rebuilding of consumer confidence, the integration of quality and safety into the process of restarting, and a real effort to redesign care rather than just going back to the old days.
Mm-hmm. Great, Derek. Thank you very much. Dr. Patrick, Tony, I put up one of the slides, and there are a couple more about testing. And I think in the interest of time, I take full responsibility, by the way, audience, for always overpacking shows with too much in it. But we're going to continue to learn here about how to break these things up. I think what I'd like you to do is just say a few things about the testing and maybe how that's going, because on paper, all things look logical. If this, then that, and doing this, or we're going to ask people to take this action. So maybe one way you could talk about the testing, and people can examine some of these slides later. You could also just tell us, how is it going? I mean, are you finding that what you mapped out for everyone is actually working, or are you changing it and tweaking it? Thanks.
So nothing, Madge, has created so much anxiety as when we talked about testing. So give me an idea. You want me to take 3 minutes, 5 minutes, and I'll for the testing?
Well, let's start with 3 and then take a breath, and then let me see where we are. Go ahead.
Shoot for 3. So let me start by saying the most important thing you can do is follow the CDC guidelines for screening. Right now, as of this moment, our RT-PCR testing for asymptomatic COVID patients gives us a result, and we really don't know what that result means. The negative predictive value of that test is unknown, regardless of whose brand of test you're using, because the tests have been validated in symptomatic patients for positive results. And there's a lot of variation between the different tests. So we're going to understand, in Pennsylvania, you're not allowed to test asymptomatic patients unless you're doing as part of an epidemiologic study. So we have an EUA to do it under an epidemiologic study, and I would imagine in a few months we'll understand it. So those screening questions are, and again, the literature isn't clear, but based on some early publications and anecdotal conversation, it does seem reasonable that the positive number of tests in asymptomatic patients are going to be under 1%. Okay, so your screening is going to cover 99%. That's the most important thing. The next important thing in testing is if you want to restart surgery and you're going to do testing, then we have to have a common definition of what a COVID positive or a presumed positive COVID patient is, and what a COVID negative or presumed COVID negative patient is. If our anesthesiologists and our nurses and our surgeons and our environmental services people can't agree on that, then I'm not really sure why we're testing, because we might as well treat everybody as positive. So if we go back one slide for me, if you don't mind, Madge. So if we look at our COVID positive patients, we have basically said if they have a positive test, they're positive. And if they have new onset symptoms, because we're talking about tier 2 cases, they will be postponed at least 14 days if they're symptomatic. No, and just think of it like the flu. We wouldn't do an elective procedure in somebody who had a flu, especially somebody who had serious risk of respiratory complications. No different here. So we're going to do the same thing. Negative patients, would have a negative response to screening tests, and we are planning, as most people are, to do RT-PCR testing on these patients. So we'll go to the next slide. The RT-PCR test that we're doing, like many health systems, we're trying to do it within 48 hours of the procedure. The reason for that is logistical and feasibility more than anything. We're asking patients to self-quarantine, avoid any close contact with COVID-positive patients. We're asking them for 14 days, but we're really trying to mandate, as best you can mandate, people who are outside your hospital, them from the time of testing to the time of their procedure, to make sure that they self-quarantine. The graph you see on the left shows the time from exposure to symptom onset. It's an important graph to at least have in your mind to understand these numbers aren't being pulled out of thin air. We know that by 14 days, virtually nobody who's been exposed is going to become symptomatic or have the disease. It's not zero, but it's close to zero. Really between about 5 and 7 or 8 days, almost everybody, over 90%, are going to present. So that's, the most important thing is to make sure we have a common definition. This is important in terms of how we manage the patients once they walk in the doors of our facility. Where they're going to be transported, who they're going to be in contact with. We mask everybody who comes into the facility, I think like most places at this point. But how we manage the turnover of our operating rooms, whether or not anybody's going to be permitted in the room during intubation. Our anesthesiologists for all patients are still wearing N95s and full face protection as though they were COVID positive, but the rest of the room is not. Our surgeons, our nursing staff, if they're COVID negative or presumed negative, we proceed as though the patient were negative with really our routine level 3 masks and gowns and those sort of things. So that's probably exceeds 3 minutes. And
well,
another launching point for questions, conversations. I'd be interested to hear about Don and Derek's thoughts.
Yeah, no, I'm sure everyone is so appreciative, and it's stirring a lot of questions and comments. I just want to reinforce that you generously provided all these fantastic slides, and I do invite people to look them over, when you have a little more time as well. I think maybe as part of also, I'll invite Don into this. There are a couple questions in here, sort of our soft launch into the chat and discussion about, and it relates to something you said, Tony, to me or in our group in planning, which is this: we're never going to have an opportunity like this to do some things differently and better. This is a golden moment. Sad and difficult as it's been in so many ways. So I wonder if you could just say a few words about your thoughts about what are you referring to, perhaps, and maybe Don can jump in and we'll then get to some more questions. Thanks.
So actually, I think it ties a lot into Don's comments around, bringing our teams and staff together and patient safety and protecting our staff. There are few chances, in the world to reset. I mean, most of us would always, think in our minds if we could go back and have a week to redo everything and we take it, especially when we feel mistakes are made. Well, our ORs and our hospitals don't run perfectly. We have lots of things that are difficult to change because we've got to keep moving. We've got to keep taking care of patients. So what we did was we had this town hall that I referred to where most of these slides come from. This is the same material I presented to our staff. But what we finished the town hall with was really the idea that this is an opportunity. And one of the things we focused on was really patient and staff safety that Don alluded to. We focused on our timeouts. We added personal protection to our timeout. So we have a standard timeout with posters around the OR to make sure everybody does it the same way every time. But we felt at this time, specifically, PPE is such an important part of our patient care and our care of our staffs that we wanted to make sure everybody in the room, when we start that procedure, knows what the level of risk is. We have a common understanding of the patient's COVID risk, and that we understand that we have the appropriate PPE. We haven't even gotten into the discussion of starting the OR and how that was going to stress our PPE supplies, which is probably a whole nother conversation at some point. But that's really what I was talking about in terms of opportunity. We can be more efficient. We can do things differently, and every system has to look at where their opportunities are. We just had a meeting this morning. We talked about a number of them.
Mike, back on. Don, any thoughts? I note in the chat, it's not necessarily pointing at it's not necessarily pointing at Geisinger in particular, but somebody is saying or raising the question that maybe health systems are very quickly trying to open up everything, and that it reminds people of volume over value and et cetera, and a kind of revenue driven thing going on here. I'll throw that one to you, Don, and then we'll get to some of the other questions. And please make sure to turn on your mic.
Thanks, Madge, and thanks, Dr. Patrick. Amazing. It's so methodical what you're doing, and I think that concern that somehow the money is going to force people to do things that are irresponsible it is a concern. But you can hear how systematic and careful Geisinger sounds like it is being. Um, I guess I have two questions, if I can, Madge, for Dr. Patrick before I cede it back to you. Trista Torres, as Derek pointed out, put in a question that's really interesting among the many interesting questions in the chat, which has to do with overuse. One of the things that this era could offer us is a chance to notice what we do not need, or what procedures or visits are we've done them habitually, but they actually are not necessary. And I'm curious to know if any of that has happened, if you're kind of realizing that you're doing stuff in the history that you really turns out you don't need to do, including surgeries. The second question, Dr. Patrick, is it's in the learning system, which it's so dynamic. What's the biggest surprise? What did you start out thinking that turned out to be wrong? That sort of surprised you? One early lesson learned, perhaps.
So, Dawn, relative to the overuse, I think it is a really interesting question, and it obviously is broader than just surgery. It's all of our care. And I guess my answer to that would be it's probably too early. I think there's going to be an awful lot of retrospective look. I mean, we're gonna be seeing things in our literature for years to come when we're able to go back and everybody's asked what's happened to the MIs and the strokes, right? I mean, everybody wonders what's happened to those patients. Our ERs across the country are not seeing those patients at anywhere near the volume, maybe only 20%. Which is what we did in our system, about 20% the volume of MIs and strokes during our crisis. So I think it's a great question. I don't know that we've learned those overuse questions yet, but we've got an awful lot of patients with joint disease. How did they do? Will they come back for surgery? We're definitely interested in learning that issue. I do bariatric surgery, which is a really interesting area because we have problems with payers. And so our patients who have the diseases that put them at the most risk for COVID were largely held. Some of them will lose their insurance coverage. How are they going to do down the road? I'm interested in that as a particular one. Lessons learned, again, it's a little early, and off the top of my head, I know there are definitely some. I have been really struck by how dependent we are on objective data. And I'll just refer back to the slide you have there. People, I think from the time this crisis started, we have heard we need to test more, and myself included. I mean, I looked at it and I said, boy, when this started, once we can test everybody, we're going to be in good shape. And what's been remarkable to me is, one, that the testing itself is not black and white, as we would like it to be. And two, everybody from our patients to our staff to our providers wants it to be black and white, and they are really hanging their hats on it. And it's the most difficult area we're navigating right now. Is as we bring it back, we simply cannot test everybody. We have patients who have a philosophical objection to being tested. I mean, we've had patients express conspiracy theories about what testing is, and they refuse to be tested. Well, they have clinical needs, and there are some people who say, I won't take care of them, and we're trying to bring people back to a more I think rational approach, which is they have clinical needs that we have to take care of. And if they choose not to be tested, whether they have a less than 1% risk of being positive or not shouldn't keep us from taking care of them the way we should.
Okay, that's another yet another factor, another variable to weigh. Kind of patient refusal. All right, I want to thank.
Can I jump back to the financial
Sure.
incentive piece once real quickly? Because I will assure people, I can't speak for other health systems, but I can tell you that we have there is a lot of financial incentive, and I'm a really big advocate of putting it out there for everybody so that we understand that. Our department directors have budgets. They have to meet. Our health system, we lose $100 million a month. That's the number. It's out there. It's out there publicly. But I can tell you that nobody from our CEO to our senior executive leaderships, when we sit in a room and talk, we have elected to go very slowly. And every one of our department chairs in surgical areas is frustrated like heck about this. They would love to take off more quickly. We have closed our units down very slowly because of this. And I do suspect that most healthcare systems understand that. In the big picture, we understand that if we wind up with even one elective surgical patient who winds up critically ill or worse from COVID, it's it's just a horrible reflection on us, perhaps even more magnified than it should be. And we are determined as best as humanly possible not to let that happen.
Mm-hmm. Okay, thank you. I'm trying to knit together the ticker tape of comments and questions, and maybe Derek, I can see who might be reading some of them too, might help me out here. I guess what you just said did raise one person's question, which is COVID-19 on its way to be considered a hospital-acquired condition? If you came into an ambulatory care or hospital environment, and it can be shown or in any way that that's where you might have contracted. And of course, we don't want to get into too many speculative or hypothetical, but I'm just wondering how has everyone thought about that?
From my perspective, Madge, it's as a chief quality officer, certainly it's not one right now, but I could certainly see that path out in front of us. So obviously CMS is going to make some determinations, and right now, just like everybody else, they're struggling to catch up with the regulatory stuff. But yeah, it's a great perspective on things, and I certainly think that there'll be an expectation down the road that we keep our patients safe and free from COVID when they're in our facilities.
How are you? I'm going to, again, I think lace through some things here. How are you keeping track of what is happening? You've moved now, you're in phase 3. That happened, I don't know if it happened more quickly than you had imagined. Maybe it's right on schedule. But what are you looking at? What measures? What either qualitative or quantitative to understand how things are going?
So one, I think you bring up a really good point. We have a schedule. Everybody has to understand that schedule is fluid. So anybody who kind of goes into this and says, "Well, we'll be doing this on June 15th," I always immediately cut them off. And in a meeting, I say, "This is what we hope to do by June 15th." Everything depends on the prevalence in our communities and in our hospitals, and that's probably the biggest priority in the design of our phase in is our access of our patients to hospital beds and care and staffing, and redeploying staff again. The whole conversation in of itself, but it's been complex. We've got many individuals working to try and move those people around to the right place at the right time. So that's probably the most important thing to remember, is that there's no one schedule. But aside from just making sure that we have the available hospital beds, we get into another situation, which is trying to get these 6,000 patients who have been postponed in all our different clinical areas to be not only rescheduled, we need individuals to reschedule them, but the question's been brought up, do they want to have their procedure? We have found in my particular clinical area, almost uniformly, they want to be done as soon as possible. Don alluded to some surprises. I've been surprised how in different areas we've had trouble. In our Northeast, some of our general surgical patients have been very reluctant to come back in. Now, is that because of their perception of their disease? Or is that because they were in our highest prevalence area? So our Lackawanna and Luzerne counties, where our Northeast hospitals are, had the highest prevalent, had some very high profile outbreaks. Are they more uneasy than Montour County, where we haven't had a case in 3.5 weeks and we maxed out at 51 cases in over 2 months? So those are kind of the metrics we're looking at, and the interesting thing is, will people who have things that are truly elective come back?
Okay. Derek, do you want to jump in with anything? Don't want to put you on the spot. I know that we've got a lot of questions. People are talking a little bit about the ongoing use of telehealth, even in combination. So we've got this sort of hybrid idea, take care of as much as you can ahead of time, minimizing things that need to be done actually in person. Any observations from you, Derek?
I mean, those seem like really important issues to be discussing. The question that's been running around in my mind, however, Madge, and resonates with me from the chat, is a whole number of people who are curious, and I'm sure Dr. Petrick can help us here, curious about how do we balance and then resolve any competing clinical and ethical considerations around the prioritization. Are those, if we have a range of perspectives, Dr. Petrick, about what and who needs to be prioritized, how do you resolve those differences of view?
So my sorry, my computer just went to sleep, so I'm gonna.
That's an ongoing.
I'll type while I'm talking. So Derek, I really and I was really intimately involved in this planning, and one of the few guardrails I kind of put up to start with was trying to avoid them. You can't I can't get into a discussion with an orthopedic surgeon over whether my patient's gallbladder is more important than their patient's hip. It's a pointless discussion. And I've made this speech many times. I hope we all went into medicine because we believe what we do to care for patients is really important to those patients. And to try and say what I do is more important than what you do or one of my other colleagues does is just it's not a productive pursuit. So what we did is and you can't structure this real cleanly. But what we did is we resumed surgical procedures. Is we did tell our providers, you can be more lenient about what constitutes progression of a disease, right? So those patients who got postponed in mid-March, they weren't the same in mid-May. Whether you're talking about the patient's knee pain, that maybe they were ambulatory and they're not anymore. So we asked them, we're not going to question you. And we reviewed every case every day. We're not going to question you if your clinical judgment says they have moved from level 2 to level 1. And I would guess that in the hundreds of cases, we had a few conversations because cases looked really funny, a few of them. I did some bariatric cases, and I did them because the patient no longer had a job, wasn't sure that the job was coming back, and their benefits were expiring. So, I alluded to this. They've got diabetes and hypertension and sleep apnea that can be cured. Is that any different than curing a patient's gallbladder? So we left those discussions within specialty groups. It was okay for 4 bariatric surgeons to sit around and talk about whose case should really be prioritized, but it wasn't okay for a bariatric surgeon and an orthopedic surgeon to talk about it. We gave the orthopedic surgeons their time and said, you guys prioritize amongst yourself, and it worked out really well.
Okay, couple more questions, and thank you. Tony. Tony's on not exactly a hot seat, but he is in our you're in our box of our health system seat. So we thank you for yeah, fielding all these questions and comments. As we start to sort of nudge towards the top of the hour, I do want to make sure to ask two things which I think are on people's minds, even as people try to reopen, as it were. One is preparations for any second wave and how much that's figured into any planning, so second wave outbreaks. And the other thing is whether or not at Geisinger there is work going on around stratifying for race and ethnicity and equity that would, even in this phase, for example, right now, Tony, give you some information about whether or not there's any disparities in who's returning, reachable, willing to come in, anything like that.
So the second question, it's we don't live in the most multi-ethnic area of the
Mm-hmm.
country in central and northeastern Pennsylvania. We
Okay.
do have a fairly diverse ethnicity up in the northeast regions, and we have a hospital in Harrisburg where we have that. The northeast region was the hardest hit. We really haven't seen any disparity because I don't know that we have communities that were hit so hard that we would be able to tease that out just at first sight. Again, I think there will be an awful lot of Monday morning quarterbacking once we have data and those kind of things. But right now, we're probably not the best health system to talk about different ethnic populations and their access to care and those kind of things. On the other hand, I think from an economic standpoint, we are, a largely, lower, middle class in terms of our economics around here. And, we have felt that certainly we have good access to care. We reach out into our communities and we feel like we provide good access to care to our population, really regardless of their insurance status or economic status.
Okay. And I'm sorry, these were two big questions.
Yeah, the first question.
Oh, the first one around preparedness for any second wave.
So the second wave question is really an interesting one, and my one opinion that I give to everybody about it is, let's not forget about taking care of people with problems today because we're worried about some other person who may have a problem tomorrow. None of us knows what it holds. And so the bottom line is we've got to be prepared for both sides of that pendulum. From the furthest extreme that there's zero second wave and it's not an issue, we've got to be prepared to move forward and take care of patients. We also have to be prepared for a similar or more significant outbreak. And when that happens, will it be fall? Will it be winter? Will it be summer? We don't know. I mean, the trends right now, both here and nationally, look really good. But we've got to be prepared. The good thing is, let's learn some lessons. We've learned how to build. We can take a COVID unit down in a couple of hours and put it back up in a couple of hours right now. Our hospitals we use negative pressure anti-rooms. We've got experience now for the first time redeploying staff. We know who enjoyed the experience and who didn't. We know who thrived. We've retrained people to do things that they weren't able to do. So one of the things we want to do is catalog, and we want to make sure we have the repository of how we did this, what mistakes we made, how we can do it better. I do think we'll be an awful lot more nimble the next time around.
Okay. All right. Well, I want to, Don, if there's anything else you've spotted in the chat that's noticeable for you. I'm scrolling through myself. I think there are a lot of very particular questions few people have, certainly about surgical blocks. Somebody did ask a little bit about the difference around the ambulatory environment and the acute care environment. I don't know if that's another huge topic, if there's any high level thing to say about that, Tony?
No, I think the ambulatory environment is probably a little bit easier to deal with. I think what we get into, which we haven't touched on, another big one is visitor policy.
Yeah.
Who comes in? We have a one visitor. We have different sized waiting rooms in different facilities. We've told all patients you may need to be prepared to wait outside the facility. We've worked through that, but it's challenging. I mean, it really is. It's not ideal. And again, my approach is always be upfront with our patients ahead of time. We don't want them to come for a procedure and not have someone be able to come to visit with them. But we feel like, and we've had problems with some patients and their families and those kind of things. But we feel like if we're proactive and we provide them that information ahead of time, most of our patients are really understanding, of it. And fortunately, when we're talking about ambulatory and overnight surgery, our less complex surgeries, most of those patients are moving in and out of the facility pretty quickly.
Okay. Well, I think we've certainly made you talk a lot, and it's true. We could be here 4 hours, and but we try to do what we can in this hour. So I want to thank everybody for your observations and reflections. As always, we have a very knowledgeable group that tunes in, and you do help. And it's an all teach, all learn environment. I want to extend an enormous thank you to you, Dr. Tony Petrick. I know you gave some terrific presentations to IHI's Leadership Alliance, and you've just contributed so much to all our understanding. And I think based on what we've learned today, we should continue to watch and see what happens at Geisinger. Folks do see there's a poll there on the right-hand side, or a survey, I should say, just to let us know how this experience was for you today. I also want to thank Don Berwick and Derek Feely, as always, and thanks to Michelle James, who unfortunately couldn't be with us from the Providence Health System, but she definitely played a role in shaping the show. And we are going to go ahead and post some of the slides she had prepared on the archive page, so you'll have those as well. Please be on the lookout and for information about next week's program. That's our first in June. Can't believe we're there already. And Friday, 10 a.m. And we're starting to, as Derek referenced, a series of programs on well-being and the workforce. We will certainly pick up on a number of themes that were mentioned in the chat. So look for that information as well. So I can't thank everyone enough, the panel, the audience. It's a real honor for me to moderate. We're wishing everyone the best and always good health. For the Institute for Healthcare Improvement, I'm Madge Kaplan. Good day.